Lovely. Okay, so we're recording, so be careful what you say. I know, it could get crazy. This is a small group today. What happened? Is this a holiday weekend that I'm unaware of? Well, welcome. Welcome all 6 of you, and then you. Hopefully others will be coming. First of all, welcome to July's Aide training with Orem. And those of you at home, hope you enjoy this. We're going to go over the quiz really quick. You notice today's quiz was way easy, and only half the questions. 5 instead of 10. Who knows? Next month it could be no quiz. Question number 1. What is the correct order of planes of motion that we teach all multiple plane exercises in, i.e. the matrix exercises, dynamic stretches, etc.? What is the correct order to teach all of those exercises in as far as the 3 planes? What are the 3 planes?
Sagittal, frontal, transverse.
Right. Wow.
In that order.
Okay, that was the answer.
Did I give it away? I'm sorry.
You did. You gave it away. And why would we want to be consistent in that? Why would I teach one patient sagittal, frontal, and transverse, and then maybe another patient frontal, transverse, sagittal, and another patient transverse, sagittal, frontal?
That's just confusing.
It's confusing. It's confusing to who?
You and the patient.
Exactly. It's confusing to everybody.
More room for error.
Exactly. And then also, Mikkel might be teaching it to patient A, and then 2 days later, Sadie's working with the same patient and doing it a different order, and the patient gets a little bit off. So consistency with all exercises that have 3 planes of motion is an important concept just for avoiding confusion and helping patients become familiar with the exercise so they can be compliant with it if it's part of their home program. How often during a typical day should I check on the proper putting away of electrode lead wires, extension cords, and ultrasound cables on the modality carts in rooms and gym? How often? Is there a specific number? Once in the morning and once in the afternoon, is that good enough? When opening the office and beginning my shift? Multiple times during the day, including opening and closing of procedures, or after every use? Which one do you think is the best option? Now, there's probably more than one good option there. Which do you think is the best?
After every use.
After every use. Because if it's done after every use, I could check it multiple times during the day. But if it's done right after every use, it's always going to be done right. Okay? Number 3, when first getting the subjective with an established patient who has just arrived in the office, I should circle the best option. I should circle the best option. Really. That's exactly it. And they'll wonder why, but just say, Steve gave me a quiz and that was the answer. A, find out everything about their injury and anything else either of you want to chat about. That's A. That does happen, but whose fault is that really? Usually.
Usually the patient talks.
Patients, some of them are chatters, and that's not a bad thing. But it does kind of slow things down if we don't try to politely and appropriately rein them in a little, right? Just skip it and set them up the way that you remember from the last time they were in the office. I'm not going to lie, I've seen that happen in some settings, like a patient comes in, it's a knee patient, total knee replacement, and the setup is interferential on the knee and Russian on the quad and a heat pack. And the patient may have an 8 out of 10 pain or a 2 out of 10 pain, and the aide that had worked with them 2 or 3 times just goes ahead and gets the heat pack, the electrode, sets them up, and then goes and tells the therapist what's going on. And there may be some variation in that treatment that needs to be done, so certainly don't skip the subjective. C, ask the patient specifically how do you feel you're progressing with the physical therapy so far? And D, do not waste time talking to the patient, just go right to the therapist for instruction. So the answer on that would be C, yes. And that question is the question that pulls the patient kind of back from the, oh my gosh, you're not gonna believe what my daughter just did. This is the craziest thing. And I cannot wait to tell you and you and you and you and you, and probably 5 times today. And then you ask the question, so, but how are you progressing with your therapy so far? It doesn't mean her daughter's not important, it means we're gonna get to that later, okay? And then you're able to kind of rein that in. I kind of want to find out what they did, you know, it's cool. The best way to learn the exercise used commonly in the office is by, who has the answer to that one? A, is it just watching others and have patients show me when I am working with them? I'm not gonna lie, I've seen that happen, and that's not the worst thing in the world, because some patients are pretty darn good at it. They're great teachers. B, asking the therapist to teach them to me so that I can practice them properly.
That one.
That's a good one. It is, yeah, so we don't even need to go into it any further. C, look online. No, that's not one of them. Hoping that the name of the exercise is clear enough. Oh my gosh, when is that happening? I mean, there's 2 problems there. A, the name, yeah, nope, no, that was the wrong example. A, is the name of the exercise makes sense, and B, can I read the writing?
Oh, that's
Yeah, that's bad.
E is the
great
consistent challenge.
D, yeah, just do the exercise once, and then I'll be a pro at it forever. And then the last one, and this one is my favorite. No, it's not. That's like saying I have a favorite child. Not true. They're all favorites. How many minutes before my shift starts should I be in the office? Circle the best answer. Is it 1 minute before? Can be up to 5 minutes late. 0 minutes, like boom, right there, or 5 to 10 minutes. The best option is 5 to 10. I mean, you're clocking in, you're getting paid, but it also helps the therapist who's working in the office that day to be able to direct how they're going to progress things in the most efficient manner for the patient who may already be ready or waiting, okay? So that just allows the flow to kind of pick up right when the patients are ready. Today, Tom is going to go over massage with us. That's the in-service that he's going to be doing as part of the requirement for his program. Tom's been doing a great job with us, and we're really pleased to have him. So I'm going to have him do that, and then after he's done with that, there's just a few things that I want to cover as well before we finish up, and hopefully we'll be done here in half hour or so. So while he's getting, are you all ready? His PowerPoint is ready to go.
Yeah, my PowerPoint.
Yeah.
My paper
So
point.
turn it over to Tom. Oh, let's warm him up. You know.
All right, thrilled to be here. A lot of fun. I think I've met everybody. Everybody knows me? Everybody's heard my sob story? Everybody knows what's going on? Well, I'll just read. I am currently working full-time. I work at a grocery store down the street. And the last few weeks I've been working overnight. That changes from time to time. So that's why this morning I was joking we were having carbs for breakfast. And I came home, my wife had stir-fry waiting for me. So that's why I had breakfast. All right. Not that anybody cares. Massage. Therapeutic massage. I was thinking, before I realized this is just going to be a stand and deliver type thing, I was thinking of trying to tie in my 25 years I spent in Vegas with massage, and that's the wrong kind of massage. So we're going to just talk about therapeutic massage today.
I'm confused.
You're confused? They focus on a different kind of massage.
Okay.
So it's a term used to define an intentional and systematic manipulation of soft tissues of the body to enhance health and healing. And when it's done correctly, it produces effects on the nervous, muscular, and circulatory systems. And the typical manner of delivery are the hands, but you can also use devices, rollers, turbines, tennis balls, and that's a favorite around here. Theracane. So there's other ways to deliver massage in addition to the hands. And they refer to massage as art as well as science. You've heard that term, it's as much art as science. So there's scientific, evidence-based things going on, but there's also some art to it, how it's done. Kind of two models for massage: wellness. You go to get a pedicure or a manicure, you go to get a massage just because it makes you feel great, right? Delicious, right? That's one way. The other is treatment model. So, part of what we can do with massage is diagnose and treat a condition. You're starting to feel around, feel tissues, and get some type of a vague idea of what's going on. And it's to help to design a program to deal with muscular issues and skeletal issues that the patient may have. And the therapeutic massage there's a variety of manual techniques that we use to make that happen. They promote stress relief, relaxation. They help to mobilize various structures, relieve pain, swelling, and promote functional independence in a person who's struggling with a health problem. So historically, the first mention in writing of massage is about 2000 BC. So it's been around a while. Since the late 1700s, it's actually been a true medical field. It's been discussed regularly. And it's been part of the physical therapy scene since physical therapy has existed. It's been around. You already talked about the effects of massage is to bring about physiological, mechanical, and psychological changes. And it's, again, to help evaluate the soft tissue, relaxes muscle, provides some pain relief, and in certain ways it helps to relieve edema. So some types of edema can be relieved with proper massage. We can use it to help increase range of motion in some of our patients. It also helps us to provide a connection between the therapist and the patient. You're making a physical connection there. And it increases patient body awareness. I just had this happen yesterday. So I was working with a patient who was struggling with some issues with her scapula, and about halfway through the thing, she goes, "I don't even know what that is." Like, she wasn't really sure what was. So I was able to take a moment and kind of outline, trace the scapula and point out some of the structures around the scapula and let her know what was going on. And it seemed to be news to her, so that was kind of fun. Basic strokes of massage is effleurage, which is French for anybody?
Effleurage.
Effleurage, thank you.
French for that, isn't it?
To skim. Effleurage is French for to skim. I looked that up because I didn't. Petrissage, which is French for kneading with a K, kneading. Right? Friction, tapotement, which is tapping. I don't think that's French for anything. So. And vibration. And so effleurage is a gliding technique that we use, and it's got a couple of purposes. It's kind of the entry into the massage process. It helps to relax the patient, helps to make that physical connection, and it's also preparing the muscles for the more vigorous part of the massage. We use it to begin and end the massage, and we should be using it to transition if you're transitioning from one area to another, scapula to shoulder, or to the lower back, thoracic. As you're moving around, you want to take that moment to transition by using effleurage. Variations for effleurage are, you can use a gliding technique.
Can I throw something in?
Absolutely.
Just really quick, Tom. I think one of the things that we run into when we are timed at how much time we can spend on massaging as a particular area. Tom brought up something that's really important. Effleurage is a transition technique as well, and if we're working on a patient and trying to get deep into a tissue area, but you've been told, like, say, we're working the back of the shoulder, the upper trap, and the rhomboids, and you're working deep in the back of the shoulder, don't just go deep to the upper trap or deep to the rhomboids right away. You want to transition with that effleurage, because if a patient is reacting by a little bit tense or guarded, or maybe not sure if you know what you're doing, then they're not going to relax, and the effectiveness of the massage is lost a little bit. So anyway, I just want to.
No,
your point was great. So
your techniques could range from just simply, as we talked about, gliding over the surface is one. Shingles, which would be think about how you layer tiles, I think they refer to it when you're talking about computers, how they layer things on a window screen. So that'd be a shingles or tree branches, which either going up or going down, kind of off of a center line and coming out, kind of at an angle. Okay, those are all effleurage techniques designed to condition you make that connection, condition the tissue, and get the patient ready for a more vigorous massage. So then you graduate to petrissage, the kneading. Okay, that's when we're going to actually go after some of those deeper tissues and try to work some of those tissues and accomplish what it is we're after. So you're actually trying to knead and squeeze those subcutaneous fascia and deeper muscles. Two-handed petrissage, lifting and squeezing, working the tissue. Finger to thumb, you can hold one hand in place and push tissue up against it. Is another method. Skin rolling, you can work the skin, okay, depending on the tissue you're going after. Compression techniques, so in that case and I think that's probably one I see a lot of that we're doing here, is you're actually pressing the tissue against other structures. So you're using your hands to press the musculature up against usually a bony structure or a deeper muscular structure, and manipulating it in that fashion. Another technique is friction. Friction should typically be done without lubricant, because you're trying to, instead of moving the skin, you're trying to create friction on underlying tissue, typically a tendon. You can do cross friction, you can do circular friction action, and then it's really key to always work into that with effleurage, petrissage, then friction. Friction is the only time really it should be painful. We should not be causing pain. We should be consulting with the patient, making sure that you should be going after some of their pathologies, but we shouldn't be causing pain with anything except friction. It will sometimes be a little uncomfortable. Okay. Friction is also a great way to get into some of the deeper joint spaces. It's used to loosen scar tissue. If you've got adhesions and scar tissue, friction is a great way to take care of those. Tapotement is, I'm thinking about the guns. That's a real popular thing. I actually got one for Christmas. It lasted about 2 days before the kids broke it. So I don't think it was a very good one.
It's also used for helping with pulmonary drainage.
Exactly. So that's what in school, that's what they were teaching us along with the position. So tapotement is basically tapping. Okay, and it can be done hacking with the ulnar side of the hand. It can be done in a cupping fashion. It can be done by slapping. One of the things they've pointed out is, massages can generally be pretty relaxing. And sometimes before an athletic event, you're going to want some type of massage action. You don't necessarily want to relax the athlete. So tapotement would be an appropriate way to perform that massage to help them loosen up, because it would keep them alert and ready for their athletic activity. And we've already talked about hacking, clapping, cupping, slapping, tapping. It's a percussion. Just think drums. Okay, we're just trying to work the tissue that way, and it's very common with people with lung congestion, cystic fibrosis. It's just a way to loosen everything up to help them expel some of that. Also, pinching tissue can be a tapotement technique, kind of pulling up and letting it go. So, a couple of things, considerations for us as therapists is we want to stand with feet about shoulder width apart, and we really should be in a position where when we're extended and working on the patient, we have the ability to extend our arms. Our mechanical position is important because we're here to help the patient, but we don't want to put ourselves in a position where we're reaching or twisting in a way that could actually cause us some wear and tear. And it's a very physical activity, so it can cause some wear and tear on us as well as the patient. So you want to make sure you're in a great position. Our tables here aren't adjustable, so I know that we've got some boxes that you may have to change the height. I mean, everything here is kind of good for me, but I'm 6 foot, so if you're not 6 foot or you're not tall, you need to make that adjustment. And then also using the proper massage medium. Here we've got the conduction cream that we use for massage, but you can use mineral oil, baby oil, cocoa, butter. There's anything really that's a organic lubricant would work great.
One thing I've pointed out a couple of times is after you've finished ultrasound on a patient, you have the ultrasound gel there. The ultrasound gel is a great massage medium. We often just wipe it off and get that towel looking like, you know, an elephant sneezed on it. And then handling it and bringing it over here is sometimes a gross opportunity as well, especially if you're not the one who knows how it was exactly rolled to protect against exposure. Okay.
And you're hoping
Literally, you can put the towel on the ultrasound gel just to kind of get some of it off, and then use the ultrasound gel as part of the massage first, and then when that feels like it's kind of gone and you need a little more lubrication for the rest of the massage, use the lotion. But just wiping the gel off is honestly, it's a waste. Use it as the massage medium first, and then add the lotion later. That would be my recommendation.
I didn't even think about that. Considerations for the patient. Of course, make the patient feel comfortable. Padding, supports, whether they're going to be prone or supine. There's your protocol here. If they're prone, that you want a pillow under the ankles.
It's a Jamba thing.
It is a journey.
It's paid off.
Being
many
aware of
times.
any contraindications or limitations they have in their positioning, if it's comfortable or safe for them to lie prone or lie supine, be aware of those things. The massage medium here is hypoallergenic, I'm sure, but make sure that if you're doing it outside of this environment, that it's something that's appropriate for massage. Heavy scents, highly perfumed stuff can be irritating to some people. Position for comfort, we've already talked about. And then drape the patient, prepare the patient. Sometimes if they come in clothed, it's not going to be possible to do a proper massage with them clothed, so you want to make sure that they're in a comfortable and modest position, and you know, that they're protected. Explain the process to them, what you're going to do, where you're going to be working with them. They taught us at school never to say the word touch. So it's like, I'm going to touch you, don't say that. You know, I'm going to be working on your, look, you're laughing, but you know why. So you're going to be I'm going to be working on your ribs, I'm going to be working on your spine, I'm going to be working on your shoulder, let them know what you're going to be
Yeah,
doing.
but if the patient comes in and it's a parent and the patient is a child, it's an awkward conversation to say to the parent, I'm going to touch your child.
Yeah,
No.
they
I'm
expressly
going to
said
prison.
don't use the word touch. And then finally, get consent. Make sure that you inform them, hey, I'm going to work this. Is that okay with you? Anytime you're going to be doing anything, moving clothing or placing the towel underneath the pant leg, whatever. Anytime you have to do anything.
Putting the electrodes in a location.
What's
like
that?
When you're
Yeah,
placing
exactly.
electrodes.
Yeah, and you may that's a process that may take place several times during a session. It's not just one and done. You just keep asking. I'm going to place these electrodes. I'm going to put some massage medium on. I'm going to move your bra strap. Whatever the case may be, just make sure that you can receive consent. So that concludes the oral part of our lecture.
Okay. Everybody grab a. Yeah, thank you.
I've got, if anybody would like these notes, there's actually some YouTube links on here. If you email me at tomfromtwowheels.com, all spelled out, I'll send you a copy.
Thank you, Tom. I appreciate that. He touched on the importance of making sure the patient is properly positioned for massage, and the group that is here, you guys are all really good at making sure the patients are in the right position to be relaxed and comfortable for massage. The whole pillow under the ankles thing, I don't do that because I'm thirsty. I do that because it literally, when a patient is lying on their stomach, if their knees are straight and their feet, like if they're lying on the, Zach, come on up here, if you would please. So,
Lightning fast.
yeah, that was really fast. So, if we look at Zach in this position, Zach looks relaxed. He looks like he could probably take a nap in this position. But if you look at this, and then look at this, I mean, is there a noticeable difference in what you're looking at? Is there a noticeable difference to you?
For sure, yeah.
So when I work in Lehigh, it's not a thing for them to put pillows under patients' ankles. They haven't made a deal out of it, and I see it all the time. And just yesterday, I was there and saw one of the therapists working on a patient who was lying on his stomach, and the kid had big feet, and they were really uncomfortable, and he kind of had them like this, and then he kept kind of bending his leg back and forth like this to take pressure off of, I don't know, his ankle or his knee or something, because he was uncomfortable. But the therapist was completely unaware of that as he was working on the back. And so every time Zach lifts his leg even a little bit, go ahead and lift it a little bit, everything up the chain has to tighten up. And if I'm working on this and he's doing that, how relaxed is that? Not my idea of a good time. So this whole pillow under the ankles, and if it's a patient with low back pain, I do like to have a pillow underneath the abdomen, is more golden rule stuff. How would I want to be positioned? What would make me most comfortable is very likely going to make another person comfortable. And we often will ask the patient, do you want pillows under your ankles? And most of the people are so nice, and they don't want to put anybody out. They're like, oh no, I'm fine. So I don't even ask them the question. I get the pillows and I say, here, I'm gonna go put these under your ankles. And I go, okay, well, and they lift their feet and they're fine with that. So don't ask. Don't tell. No, don't ask, just do it. I always get these phrases mixed up. Okay, and then on the shoulder, Zach, if you'll pull that chair over and turn it so it's facing the hot packs, and then just have a seat. So when I'm working on Zach's shoulder, if I'm here and I'm working on his shoulder, he may be relaxed, but how am I doing? This isn't super comfortable. I mean, it's. I don't think Zach's comfortable with it either. Doesn't want somebody's hip right close to him like that. So go ahead and if you get their arm up on pillows, and I prefer that only because most of the time, unless they're immediately post-op, they can get their arm almost fully abducted. And the other thing is the elbow should be in front of the shoulder, not directly to the side of the shoulder. Okay, that's because if the shoulder's in this position, the capsule in the front is tight and the capsule in the back is loose. You slide their shoulder forward about 30 degrees and the front and back capsule kind of even out. And so that's the most relaxed position for the shoulder. And you're in a position to work with the patient and do your massage and get through the entire area comfortably for them. So that helps a lot with that. And if the patient's been lying down for the modalities of heat and stim, and you're going to be doing ultrasound, go ahead and ask the patient if they mind sitting up for the ultrasound massage. You know, I may say to you, like, go ahead and do it with them lying on their stomach and rest their arm off the table if there's a specific reason. But for the most part, this is a good way to go. And then the last thing I was going to show you, Zach, I'm going to have you lie on your back with your head up toward Tom and facing face up.
It'd be hard for me to lie on my back facing down.
That would be hard to do. Yeah, I know. I don't know why it's confusing to me. That's another story. I have so many of them. And when you're working on when you're working on a patient's foot, you want to most of the time, if you can put one hand underneath their ankle, and we've talked about this a little bit in the past. When you're doing massage and working on a patient, as often and as you can, have both hands in contact with the patient at the same time. One hand may be resting and supporting, while the other hand is performing the technique. That's fine, but don't be, unless your hand's in a cast, don't avoid having both hands in contact with it. Yeah, you'll have the cast resting on, they're resting on the cast, so you're making contact. Mikkel, we can't wait. This is going to be 2 weeks of joy here. When does this start?
The 19th.
I think you should bring your cordless circular saw because I don't think she's going to make it for 2 weeks. I think you should just have that in your office.
I have a
There you
cast
go.
cutter
There you go.
in the office. I do. I'll show it to you.
You
It's-
have it warmed up and ready
And,
to go.
and I have a scar on my wrist from a cast cutter. They don't cut at all. But have one hand supporting the foot, or both hands in contact with the foot, both hands in contact with the ankle while you're working on the patient. And when you're, and it also allows you to switch from one hand doing the technique to another so that you're not getting tired and you can switch up your techniques frequently throughout the massage. Hello there, Alexis.
Hi there, Steve.
Oh,
Oh, hello, camera.
Yeah. As you know, Alexis is here. So anyway, that's the things on massage. So thank you, Zach.
Yep.
Okay. So let me go over a couple of the housekeeping things really quick. Oh, any questions on that? Has anybody had any experiences or circumstances where you felt like, man, this was kind of a weird way to do a massage on this particular body part, and I don't know how to improve on that, or maybe I got a question on how to do better? Can you think of it? Yes.
So with the shoulder, when you're putting pillows under the arm on the table, I'm assuming that part of that is to get to the right height of abduction for them and also for comfort. Is that right? Or is there
Absolutely.
anything else?
It's 100% for that. It isn't trying to create some kind of therapeutic mobility or biomechanical, improvement that is going to be measured from one treatment to the next. It's your goal before you do your first massage technique on a patient is to have them maximally comfortable and in a position to relax the best that they can for that treatment. So positioning is something that you really want to be paying attention to moving into that massage, not just for the patient but also for you, so that you're not putting yourself at risk or straining your back or something like that.
So then follow up to that. If the patient, I've worked with some female patients who are just, they're sitting on the chair, they're just a little shorter. If they're like already at a super abducted without pillows, is it okay to just forego the pillows?
And it's also okay to have them just put the pillow between the arm and the armrest, so the table doesn't even have to be a part of it. So you can still, unless it's too awkward. I mean, if the patient's that short and you're sitting on the table and you have to lean way down to work on them, then just move their chair away from the table and put a pillow maybe between their arm and the armrest, and then pull a stool up right next to or behind them and be in a position to do that massage. Yeah. Good questions. Any others? Okay. Couple of things that we wanted to cover really quickly on just accountability as aides. Being on time is one of the things that we want to make sure that we're focusing on. On time-off request forms, if anybody is not sure how to fill those out correctly, see me or Karen. But if you do know that something is coming up and you're going to be gone or need to be gone, we like to have those filled out at least 10 days in advance, and more earlier than that is better. But we also recognize that there are sometimes emergent situations that show up, and you're like, oh, I'm in the hospital, Steve, and my shift starts in 10 minutes, and they're casting my broken leg. Yeah, we get it. That happens. But even if you wake up and you have a tummy ache, or you feel sick, or maybe you ate some bad sushi the night before, and your body's not agreeing with it, and you're not going to come to work, it is your responsibility to contact the aid pool and try to find a replacement for your shift. So if you don't have all of the aids numbers, take a photo of the aid numbers that are on the door today so that you have those. Sometimes people say, I don't know who to call, and so just make sure you get that. And if you guys, make sure you ask Susan to give you those numbers that are current as well, those of you that are watching this on YouTube. Opening and closing procedures. It has been brought to my attention that, especially with closing procedures, that some aides are getting kind of left with all of the closing procedures, and while others are like, well, there's only one patient coming in and there's 5 of us, so I'll go ahead and leave. That's not acceptable. typically the first aide in on a shift is going to be the first aide that leaves on a shift. Now, if there's other arrangements that need to be made, or you need to leave early for something, it is imperative that you communicate that with the other aides in the shift, so that if it's 3 o'clock in the afternoon and you've got to leave at 4:45, and you got there at 2:30, and there's only 3 other aides, and there's 8 more patients coming in, at least all 4 of you can coordinate how gel bottles are going to be taken care of, or what's going on with the laundry, or if some rooms on the other side need to be vacuumed, or something like that, so that you're not just leaving people in the lurch. We've got to be cognizant of what's happening to those who are closing, so that they're not doing all of the closing procedures. And I won't go over all the closing procedures; those are listed up there. But one thing I will say is, you don't have to wait till all the patients are gone to vacuum. Okay, so that is something that we have kind of let slack a little bit, and I would prefer at least once a week that everything's pulled away from walls and that kind of thing. And if you're walking around the office and you see a dryer sheet, or you see a big long piece of lint or a string that came off of a towel that 17 of us have walked back and forth over, I promise you here and now, if you bend over to pick that up, I'll give you $100 if you get COVID from doing that. I promise you won't. But it's a cool $100. I picked up that lint and I couldn't taste anything. Yeah, that's not going to happen.
Immediately.
I know. Wouldn't that be crazy?
Yeah.
I can't smell, I can't taste. That was dangerous. It came all the way from Wuhan. Then, how to teach exercises. You guys specifically are doing very, very well with exercises teaching. As you become familiar with more exercises, the thing that I'd like you to do as you're reviewing your packets and stuff is try to make sure you understand why the exercise is being done. So, I mean, every one of you could teach standing stick rotation in the dark with a blindfold on, but do every one of you know why you're doing standing stick rotation for a patient? What is actually happening? What is our purpose? And there's at least 3 reasons why. Number 1 is for muscle relaxation. Number 2 is for scapular mobility. Number 3 is for thoracic mobility and posture. So if you understand why you're teaching an exercise to patients, it'll make a lot more sense as you're teaching and observing, so that you can make proper corrections while the patient's doing the exercises. Okay? And then the last thing I have a problem with seeing a patient exercising in the gym and nobody there with the patient. I wouldn't have a problem with that if there was nobody else in the office other than me. But if I know there's 3 people having granola bars in my office and a patient's in the gym exercising and there's nobody here, then that bothers me. We need to make sure that patients are not being left alone to doing their exercises. Get there, bring the granola bar, offer one to them. But let's be with the patients doing the exercises, okay? Let's make sure that happens. And
So
that,
Steve, about that point, sometimes we have patients who have been here probably longer than some of our aides. Do you
I
still
understand.
want us with
Mhm.
them 100%?
I want us with them unless you're with somebody else. Like if you're working with another patient, if we have 5 patients in the office and we only have 3 aides, and it comes down to 2 are getting set up and another one's doing an ultrasound, and Bill is out here on the total gym, I have no problem with somebody going over and helping put away a heat pack or something and then getting back over to Bill. But I don't need somebody to sit there and go, now Bill, you know what comes after 15? 16. And then 17. He's going to be okay, on that one. So, use your judgment on it, but certainly if we aren't doing anything and a patient's doing exercises, that's a no-no. Okay? Any other questions? You guys are good. Well, that's all I have. Sadie, would you like to do the closing prayer? Okay, grab some bagels. Make sure that those are gone when you leave today, and let's clean up and have a fabulous Saturday and rest of your weekend. We'll see you guys next week. Oh, and Karen did want me to tell you, and I want to tell you guys, that we get a lot of positive feedback about you guys from our patients, which means obviously you guys are doing a very, very good job. They love you, you guys work well, and we're so grateful to have you guys. The chemistry in this office is awesome, so thank you for all you guys do. And that's to you guys. Okay.